DeBar, Billingane, Frazier, Harkins, Hickman, Hill, Hobson, McMahon, Parks, Polk, Tate, Turner Ford, Wiggins. We have quorum.
The first item on the agenda is Senate Bill 2669. You may remember at our last meeting, Senator Parker suggested there might be some opposition to the bill. And I think he may have someone here that wishes to speak to the committee, at least speak on the bill. So I think the proper procedure is to entertain a motion to take the bill from the table. And then if that bill passes, we'll hear from the speakers. There's a motion that we take Senate Bill 2669 from the table. All in favor say aye. Opposed, no. The ayes appear to have it. The ayes have it. Senator Parker.
Thank you, Mr. Chairman. Thank you for the committee's indulgence here. I know, most of you were in here before and we had some good testimony, and I think a number of us had significant questions. Fortunately, Ms. Karen Thornhill is here today with some representatives of the CNRAs. If you would, Karen, would you and your group maybe approach the podium? And I'm going to let you introduce them and just briefly share with us, kind of how you can add to our discussion and knowledge of particularly the way you see anesthesia and how the team is and how the different players can be used. So thank you, Mr. Chairman.
Thank you, Senator Parker. Chairman Bryan, Karen Thornhill, representing MANA, the Mississippi Association of Nurse Anesthetists. And I would like to introduce Sandy Weathers, the current president of MANA. And then with your permission, sir, I'd like for him to introduce the rest of our guests today.
Sure, and I just will share that it is a deadline day, and so I see a lot of people standing up there, and I'm just hoping that not everybody is wanting to speak, but a few just want to be introduced. So with your indulgence, if you could, share remarks quickly, it would be appreciated. Thank you.
Sure. Thank you. I'm Sandy Weathers. I'm the current president of the Mississippi Association of Nurse Anesthetists. I do have some written remarks. I just want to introduce the people with me. This is Mr. Paul Carpenter. He's a nurse anesthetist. I've got Mr. Blake Ward. I've got Dr. Mary Jane Collins, and I've got Major James Sullivan. So they're here to answer questions in different areas of expertise as far as the bill that we have before us. So Chairman Bryan, members of this committee, I thank you for the opportunity to speak today on behalf of the 906 CRNAs in Mississippi. As you know, we're highly trained anesthesia providers who serve in all areas of our state. We have extensive training and education, and we serve over 80% of the anesthetics in Mississippi. Because of the dedicated service of CRNAs to meet the anesthesia needs of the citizens of Mississippi, and to affirm our commitment to the leadership of this legislative body, we've adopted a neutral position on the proposed standalone AA bill before you today. However, we respectfully request and anticipate the committee's consideration of Senate Bill 2673, authored and supported by Senator Blackwell, which grants full practice authority to CRNAs. Our request is not an expansion of scope. It's simply the ability to practice fully within our scope of practice as defined by the American Association of Nurse Anesthesiologists. Before full practice can be considered, this legislation states that a CRNA must show documented 8,000 critical care hours to meet the Senate's rightful concerns that all Mississippi providers be both well-educated and experienced. We're confident that with the passage of both the standalone AA bill and the standalone CRNA bill, under Chairman Bryan's leadership, Mississippi will distinguish itself as a leader in the delivery of anesthesia care. Additionally, for context, the CRNAs recognized the potential for the anesthesia shortage over 2 years ago. To help address this need, I drafted a letter to the Council on Accreditation requesting that our University of Southern Mississippi anesthesia program increase their class size by 45%. This class has already started. We've also advocated for additional CRNA programs. UMMC is in the accreditation phase and plans to have their first entering class in the fall of next year. We're not only safe and cost-effective providers, we're committed to meeting the needs of our fellow Mississippians. The testimony presented last week contained several inaccuracies. Firstly, the term mid-level is often used by physicians in a manner that undermines the expertise and training of non-physician providers. It's important to note that this term does not appear in any Mississippi statute, rule, or regulation. While anesthesiologists can certainly refer to their assistants as mid-level if they choose, the practice of myself and my CRNA colleagues should not be described as mid-level. Rather, our work is of a high level. This terminology can mislead the public in believing that they're receiving an inferior service. Furthermore, CRNAs were the first anesthesia providers recognized in the United States with a history dating back to the 1800s. There is no significant evidence that suggests that the quality of care we provide differs from that of physician anesthesiologists. Anesthesiologists, or AAs, on the other hand, possess less training than CRNAs and have been proposed by Mississippi Medical as a sole solution to our current and future shortages. Their limited capabilities alone do not provide the necessary flexibility to meet the diverse healthcare needs of Mississippi, particularly in rural areas. It's interesting to note that while AAs serve as a potential resource, Alabama has licensed AAs for nearly 20 years, yet only 21 currently practice in their state. Alabama's needs are still great, yet anesthesiologists nor AAs have been able to provide a viable solution. I'd like to be clear. While MANA, on behalf of CRNAs, is neutral on the standalone AA bill before you, we are highly offended by the open and public opposition by Mississippi Medical Association and the Mississippi Society of Anesthesiologists to our own legislation providing CRNAs the much-needed additional flexibility to practice effectively throughout Mississippi. This flagrant opposition clearly suggests that the true intention of the physicians is to merely control the market rather than to address the genuine needs of Mississippi. To be working feverishly to kill our attempts for meaningful legislation while working just as feverishly to move a lesser trained group with no experience to date would be laughable if it weren't so appalling. As an example I've shared many times which seems to resonate, if your prized vehicle was broken down, would you rather have the shop owner, his assistant, or the master mechanic who is turning the wrenches day after day, year after year, working on your vehicle? I know what my choice would be. For me, both myself and my family, CRNAs are that choice. As we continue to rank near the bottom of various healthcare comparisons with other states, we rely on the leadership of this committee to explore avenues for advancing Mississippi's healthcare. While the advancement of both CRNAs and AAs is one possible solution, the advancement of AAs while not advancing CRNAs is not. We appreciate Senator Bryan's continued efforts to work with us, his interest in hearing our testimony today. I encourage you to take a moment and read some of the testimonials collected in the past few weeks. I thank each of you for your time and consideration. Thank you. I have people here for any questions.
The members have questions? If not, thank you for your presentation. Thank you for coming. And thank you. I have been contacted by some proponents of the legislation. I will simply say I think we may have time for brief remarks from one person. If someone wishes to make those brief remarks, we can proceed to vote, or if there's if one person wants to come speak for just briefly, We'd be happy to hear from them. If you don't mind introducing yourselves and introducing yourself, and we'd be happy to hear what you have to say on behalf of the bill.
Dr. Gary Bridges, I'm an anesthesiologist from Auburn, Alabama. I was asked to talk today on AAs for the Mississippi State Society of Anesthesiology. I've been in practice for 29 years. I've been at East Alabama Medical Center in Opelika for 26 years. I'm current chief of staff there. I'm the current president of the Alabama State Society of Anesthesiology. I work with CRNAs and I work with AAs every day. You know, about 8 years ago, our state association did a huge workforce survey. We presented it to the University of Alabama, and they did a large workforce survey and showed the shortage of providers in the state of Alabama. I was facing the same shortage. I try to staff 20 to 22 operating rooms a day, doing 26,000 cases a year. We couldn't do it. We were running cases 10, 11, 12 o'clock at night across the state line in Georgia. Most of the providers working with anesthesiologists were AAs. We hired our first AA. Was there some contention in our group? Yes, there was contention in our group. Did I have a target on my back? Yes, I had a target on my back. But you know what? At 3 o'clock in the afternoon, when it was time for CRNA to go home or go to lunch, they turned their cases over. Fast forward these years, and if you came in my operating room today, you would see no difference in the care provided between a CRNA and an AA. And I can tell you, everybody that works in my group has a little bit of a different skill set. I don't let every CRNA do hearts. I don't let every CRNA do pediatrics. I don't let every AA do hearts. I don't let every AA do pediatrics. Some I don't let do spines. We put people where their best qualities are. 4 years ago, we started an AA program at the medical school in Auburn. And we did this because of the workforce shortage. We went to Sanford and Birmingham and UAB and Emory, where I have trained CRNAs from the last 26 years of my career. And we said, we're stressed. We need help. Will you increase the class size? And the response we got is, if you can't hire people, you're not paying enough. Well, that wasn't true. It was just the marketplace is not there. And a lot of what's driven that is 26 years ago, when I went into practice, I didn't do anything in the cath lab. I didn't go to endoscopy. I didn't go to the interventional radiology suite. We didn't have a surgery center in town. We were all contained to the main OR. But there's been an explosion of areas in the hospital that we're working in. And we just did not have the workforce. And I can tell you, the kids we're training in the program at VCOM for the AA school, 50% of the kids in the first year class came out of the University of Georgia Biomedical Sciences. And the reason we had so many from the University of Georgia is because Emory's had an AA program since 1972, and South University in Savannah has an AA program. So the University of Georgia, where I'm a graduate of, had a pre-AA curriculum. We talked to them. We've recruited a lot of kids. In the third year class, we've just now accepted at Auburn. We're probably going to have 14 or 15 Auburn graduates. These kids are very bright. The didactics is taught by a lot of our medical school faculty. The pharmacology is taught by the medical school faculty. The anatomy is taught by the medical school faculty. And our kids are going out and doing clinical rotations everywhere. I'm more of a community hospital. We do cardiac, we do spine, we do pediatrics. But two of the students just came back yesterday, and they're AA students, and one had just came back from Shands Hospital at the University of Florida, where they were doing neuro. One just came back from Piedmont Hospital in Atlanta, where they were doing liver transplants. So they're getting the same experiences. I can tell you, when I walked out of residency at UAB, I probably thought I was a hotshot doctor, knew it all. But I can tell you, after 30 years, you realize what you don't know sometimes. And it's the same with these students coming out. I mean, there's a big growth period in every specialty, but it's fitting the bill for us in the state of Alabama. It's going to take years to change it. And if you look at the American Society of Anesthesiology, they publish every single month the growth in jobs. And it is off the charts. It's 150% growth in jobs in the last several years for CRNAs and physicians. In fact, 60% of the anesthesiologists in this country are over the age of 55. So we're really in an anesthesia crisis, not just in the South, but everywhere. So thank you for your time, and I'll be glad to answer any questions people have.
Thank you. Do members have any questions? I don't see any. Thank you very much. We appreciate your time. So there's a motion, I believe, on Senate Bill 2669, title sufficient to pass. Do members of the committee have questions, comments? If not, are you ready to vote? All in favor of the motion, title sufficient to pass, say aye. All opposed, no. It appears the noes have it. It appears the noes have it. The noes have it, and that bill has failed. We'll now go to Senate Bill 2677, the Pharmacy Benefit Prompt Pay Act. This is the bill that deals with pharmacy benefit managers. There is a proposed committee substitute. Before I recognize Senator Parks to consider the committee substitute, I would simply say that my personal position is that the pharmacy benefit phenomenon is really not in the best interest of anyone in the public health system. But we have pharmacy benefit managers. I believe there is a major problem with concentration and vertical and horizontal monopolies operating in the healthcare area and getting worse and worse. And among the people that are getting squeezed out are independent pharmacists who are not associated with a chain, who practice in small communities and find it more and more difficult to navigate the world that we're in now. That being the case, we have had for several years legislation similar to this, which attempts to assist the small pharmacists. There's no one who wants to do that more than I do. The difficulty is, until now, we've not been able to find anything that we really understood. I don't think none of us are experts in all the moving parts in the so-called healthcare system. And it's difficult to understand the consequences of the legislation that's been suggested. It also is the case that the legislation is introduced has not been adopted in any other state. So we're sort of in a quandary for those of us who would like to help but don't know quite what to do. That being the case, it's my understanding that there is a bill in this general area going forward in the House. Senator Parks has developed a proposed committee substitute, and the committee substitute that's before you consists of Senator Parks's bill plus a reverse repealer. And so at this point, I will ask Senator Parks to explain the committee substitute that's before us, and to the extent you can, tell us the difference between this committee substitute and what's been proposed in the House.
Thank you, Mr. Chairman. What I would like to remind the committee, this bill is the same bill that passed last year at the end of the session. This bill contains the transparency plus the data collection. And to your point, what is the difference? The difference in this bill versus the House bill that passed a week or so ago is the transparency portion. Again, the transparency portion plus the data collection passed last year. This bill does have a 3-year repealer. I don't believe the House did. It may or may not have. I may be incorrect on that. But again, the difference between the two bills is this one includes the transparency portion from last year. And so some of those transparency portions that, you know, we've talked about multiple times, I'll give you a few examples. I think there's probably a total of 8, but or so, but a cash discount card requiring a reimbursement to the pharmacy. Today, it's currently 60 to 90 days prior to the PBM being required to pay. Going forward in this bill, it would be paid within 7 days. And to try to break that down a little bit, what is happening currently, that's a huge financial burden on our independent pharmacies having to carry this, because most of the time when you have a discount card, this is for some of your larger pay drugs. So those cards could range anywhere from $25 to $400 to $500. So that can become quite a cash strain to an independent pharmacist. One of the other things that this bill does, there is a group called the Pharmacy Service Administration Organization, often referred to as the PSO. They will now be required to be licensed. This is the same requirement that the PBMs have. This bill does exempt the self-insurers. Another part of the transparency, I'll give an example, but the PBM may not, this bill's requiring that the PBM may not charge a patient more than the total reimbursement paid by the PBM. I'll give you an example. The copay for a drug may be $40, but in actuality, that drug cost may only be $5. So this is a great, I think, step here toward helping our constituents. The patient would merely only pay the $5 going forward. Another one of the protections today, if our pharmacists, if they file a formal complaint, a PBM has the opportunity for retaliation. This transparency bill would now help prevent that or give some protection to the pharmacist. That's to name a few, and I'm happy to answer any questions that anybody might have.
Do members have questions? Senator Wiggins.
Thank you, Mr. Chairman, just of the chair. So we have before us a committee substitute with a reverse repealer in it. Is that what I'm hearing?
That's correct.
Okay, so thank you. Senator Parks, I know you've worked on this a lot. I just have two questions. So in what's presented to us, you said this bill is exempting self-insurers. Is that correct?
Yes, yes, sir.
Okay. And then I guess I have three questions. Then is this involving, should it pass, getting into the middle of contract negotiations and contracts between private companies and that they've negotiated for the benefit of their employees?
I am sure, I mean, well, currently today, I mean, there are some PBM contracts that say that they don't pay for the 90+ days. So to answer that question now, that would be requiring them at 7, that's a fair statement. Yes, it would. But are you specifically asking about employers or just PBM contracts in general?
Oh, I'm sorry. I was asking about employers who negotiate private contracts for the benefit of their employees.
The only thing that I can think of that potentially, but it's really not going to negate the contract, would be it does allow for like one of our constituents to go to any pharmacy that they should choose. But I want to clarify that it prevents the steering, but that would be up to the individual payer. So if they wanted to pay the extra, maybe the copay goes from $40 to $75 if they want to use their independent pharmacist, that's on the constituent.
Okay. And then my last question is, if a version of this bill was to become law, is there a guarantee that mom and pop, when they go into the pharmacy, that their prices will be less than what they are now in this? And conversely, is there the possibility that when mom and pop goes into the pharmacy that they'll be paying more?
There are no, it gets really deep when you talk about cost of drugs and what people will be paying, because that's all, there's a lot of factors that factor into that. That's a manufacturer's cost. Those price indexes change, weekly. I cannot, answer that with any guarantees or anything of that nature because there's too many factors that go into the cost of that today.
Okay, thank you, Mr. Chairman.
And I just need to make a comment. In this particular committee, so there is no reverse repealer. There is a 3-year, it does repeal in 3 years. That at that point, we'll be able to look at the data collection.
Senator Parker.
Thank you, Mr. Chairman. I just want to say, first of all, Senator Parks, I appreciate your work on this bill, not just this year, but for the last several years in a row. This has been particularly frustrating to me over time that we have not been able to take action on this important issue. It is a committee sub. The one I think I have in front of me, and I may be corrected by council, but I do think in section 13 of the one I have in front of me that it does have a reverse repealer. And I just want to clarify with council if I'm looking at the correct document.
Yeah, that,
I think the confusion may be that if you're looking at what is stapled together, you have the original bill stapled behind the committee substitute. The committee substitute is 34 pages long, and on lines 852 and 853 of the committee substitute, you will find the reverse repealer. Stapled behind that is Senate Bill 2677 as introduced. So if you just flip over and look at the last page of the bill as introduced, that does not contain the reverse repealer. But what's before us is the proposed committee substitute.
And so if I understand the explanation, Mr. Chairman, the bill in front of us does indeed have a reverse repealer in it.
For the 118th time, yes, the proposed committee substitute has a reverse repealer. It is on lines 852 and 853, and it reads as follows. This act shall take effect and be in force from and after July 1st, 2025, and shall stand repealed on June 30th, 2025.
Mr. Chairman, my motion is that we strike the reverse repealer on lines 852 and 853 as an amendment to the bill. I'd
You're
like to.
recognized to speak on the amendment.
I think we have discussed this for many years. For those who may just be joining us in the gallery or watching online, what a reverse repealer does to a bill is it slows it down. It requires a bill to go to one chamber. Because it has that in, it has to be removed, has to go back to the other chamber and come back, and it basically slows the process down. I think that on this particular issue, we have had a lot of debate, a lot of discussion on it, and I would prefer, just me personally, to vote on the bill without the repealer. I know there are differences of opinions, but this is such an important issue that I think any and everything we can do to move this along quickly is important. And I yield for any questions on my amendment.
Debate or discussion on the amendment? If not, are you ready to vote on the amendment? All in favor say aye.
aye.
All opposed, no. It appears the ayes have it. See further debate on the bill? Are you ready to vote on the bill? The motion's title sufficient, do pass, committee substitute. All in favor say aye.
Aye.
All opposed, no. The ayes appear to have it. The ayes have it. We'll report that bill to the Senate. At this point, I would call up the Senate Bill 2392, the Certified Community Behavioral Health Clinic Grant Program, and I would entertain a motion to title sufficient do pass, and I would recognize Senator Hickman to speak on the bill. Is there such a motion? Okay, Senator Hickman.
Thank you, Mr. Chairman. I will try to do this as quickly as possible. Basically, what this bill does is it sets up a framework for the Department of Mental Health as well as the Department of Mental Health to set up a framework to have certified community behavioral health clinics in the state of Mississippi. Basically, it would set up a process where our community health centers, mental health centers could apply and become a certified center. What this would then do is allow the state of Mississippi to apply to SAMHSA to join the Certified Community Behavioral Health Clinics demonstration grant. And through that, it would allow our certified community health centers to provide services that they hadn't previously provided, but it would also allow for the state of Mississippi to take a lot of things that we're paying our dollars for and get enhanced Medicaid reimbursements for those things. The one thing I will say about what we're doing, we're setting up kind of a pilot program. We wouldn't go all in at once. There are certain things that our community health centers will have to do, our community mental health centers will have to do in order to get this certification, and most of them are not ready. We have a few centers that would rank very high on readiness, and those are the ones we believe after application would be certified, which would allow us to draw down these federal funds and provide, again, enhanced services to our communities. The one thing I'll say is everybody around us has done this. Everybody in about 3 years has seen a return on investment with what we've done here. And so with that, Mr. Chairman, I'll yield for any questions.
Are there questions on the bill? Debate on the bill. Are you ready to vote? The motion is title sufficient, do pass. All in favor say aye.
Aye.
All opposed, no. The ayes appear to have it. The ayes have it. Let's go to Senate Bill 2681, which deals with the certificate of need law. There's a proposed committee substitute. I entertain a motion, title sufficient, do pass, and motion title sufficient, do pass, committee sub. And so by way of explanation of the committee substitute, it's my opinion that we need to be making some changes to the certificate of need law. One of the changes that I had thought would be a relatively simple thing to do would be to remove the prohibition against certain basically nursing homes, but other facilities from participating in the Medicaid program, which is something that seems to me is antiquated. I had thought that we could rather quickly identify who those entities were, but it appears that some of those entities never even started operating in the first place. So rather than inadvertently do something we don't understand, I've had the committee substitute prepared, which is the certificate of need code section, but it has 3 changes to existing law, and correct me if I'm wrong. First of all, Senator Blackwell has a bill to allow certain facilities in DeSoto County to accept Medicaid patients. That is in this bill. There is a facility on the Mississippi Gulf Coast, which is a similar prohibition. A House bill is actually on the calendar dealing with that. And so that situation has been taken care of. Then the third thing is the text of a bill introduced by Senator Michelle that deals with Sun Valley, which would like a certificate of need for additional facilities at Sun Valley. Those are the 3 changes. This is primarily an opportunity to get a bill in the process. There's a House bill coming to us, and I think we'll have vehicles in both directions. I'll be happy to answer questions if there are any. If not, if there's no debate, the motion is title sufficient, do pass. Committee substitute. Are you ready to vote? All in favor say aye. All opposed, no. The ayes appear to have it. The ayes have it, and we will send that bill to the floor. Senate Bill 2690 deals with the existing healthcare expendable fund. I know that the existing law repeals, and this just extends the life of the fund to allow appropriations to appropriate out of that fund this year, among other things. There's a motion, title sufficient to pass. Is there further debate or discussion? Are you ready to vote? All in favor say aye. All opposed, no. The ayes appear to have it. The ayes have it, and we will report that bill. There are several other items on the calendar, and there's a few other bills that we need to consider. I've been trying to determine which bills are on the House calendar, because there are a number of these, if the House has got something on the calendar, we don't need necessarily to take up the bill. So I think at this point, the action that seems to me to be most prudent would be to recess public health subject to call, to let the Finance Committee meet, if y'all are prepared to meet, and then after the meeting of the Finance Committee, we'll reconvene the Public Health Committee, and that will give me an opportunity to see if the House committees have finished their action. So, there's a motion that we recess subject to call. All in favor say aye. All opposed, no. The ayes have it.
Huh? Yeah.